You can be on testosterone and maintain some level of fertility. The beauty of the HCG molecule is it lasts a lot longer. So we have another questionnaire that we ask. It's called the Aging Male Survey, and it goes a little bit deeper in depth. It also about things about night sweats and some more really specific symptoms. But other things like the fatigue, especially like after your meals. But then there could also be dysregulation of your insulin, aromatase inhibitor, that enzyme I think I mentioned that converts your testosterone into estrogen. We're talking about a study he's doing with something called kisspeptin. It's a peptide, kisspeptin. Kisspeptin can also improve desire and libido, so it hits maybe areas of the brain like dopamine. They're at a lower dose. It's called testosterone undecanoate in a capsule that is like a liposomal capsule which you can swallow. So if you go on exogenous testosterone, injection, creams, oral tablets, you can add HCG with it, and you can maintain a level of it. It depends on how high the testosterone dose is and how much HCG, because HCG also brings in its own issues in some patients. It highly aromatizes in the testes into estradiol. And estradiol, HCG is human chorionic gonadotropin. Actually, this is a good one to explain. So I said LH, right, and FSH, the signals that your brain send to your testes to make the boys bigger and more sperm. There's another substance the body makes. Men who have testicular cancer or tumors, those will produce something called HCG, human chorionic gonadotropin. Pregnant women who are pregnant, when they do the home pregnancy tests, they're measuring HCG in those tests. So they produce lots of this human chorionic gonadotropin. Men don't naturally produce it in great quantities, like I said, unless sometimes there's a benign tumor there, or not benign, or like a cancerous tumor. But if you take exogenous HCG, purified HCG, made from usually women's urine, and there is another form that's made recombinantly, but it's hard to administer. You can take HCG, and it basically fits in the receptor for luteinizing hormone. And some of the HCG has a bit of FSH in it as well, or its analog called HMG, which is human menopausal gonadotropin. No, sorry, I got that wrong. Human menopausal gonadotropin is another one that menopausal women make that will turn on the FSH receptor, follicle stimulating receptor, and it will have a little bit of LH or HCG with it. So they affect the same receptor. But anyway, they get the same job done. So it's a different molecule, but it seems to fit that receptor very well and gets you to have more fertility. So you can have your cake and eat it too. You can be on testosterone and maintain some level of fertility. Other men just like the HCG, because it sometimes takes a lot of HCG to do it, and then also sometimes the HCG in high quantities may stop responding in the same way. I don't want to say desensitized, because I think that's been proven. And it does that as well. So the amount of testosterone, people get more puffy, they might get more acne, more bloaty. So this is why a small amount is good. Too much in men isn't probably ideal. And then the other part is, you can also take a recombinant LH and FSH, but the beauty of the HCG molecule is it lasts a lot longer. So LH and FSH in and out in probably less than 6 hours, maybe 12 hours at the most. HCG is up to 3 days, 4 days sometimes, that it's still having an effect. So that's why HCG is good. And they used to use really massive, large doses as a monotherapy to help people maintain their fertility. They still do this in fertility clinics, but we have another questionnaire that we ask. That's called the Aging Male Survey. It goes a little bit deeper in depth. It also about things about night sweats and some more really specific symptoms to really low testosterone levels. And then we use another, and that's quantitative. It's based on a scale. So you can see the degree of which you would suffer from those. So the symptoms really do matter. If you're looking to optimize and you're not having symptoms that are really affecting you. What would the symptoms be? Oh, I mean, so the problem with just symptoms only, and here's the difficult part. It's not like anything. Thyroid treatment, symptoms kind of overlap with low testosterone symptoms, kind of overlap with feeling like you're getting older. They kind of all overlap. But this is why the traditional ones were the sexual function ones, even though I said earlier that symptoms of low testosterone can start before you start seeing the sexual side effects. And by the time you see those, you're pretty much going to end up wanting to treat it. But other things like the fatigue, especially like after your meals, but then they could also be not dysregulation of your insulin. You can have issues with really severely if you're short in height, in the sense that you were taller and now you're either not standing tall or you've got bone loss, because bone loss is a part of low testosterone, and so that would cause shrinkage. It could be less desire to do the activities you once did, but that also matches with depression. So there's lots of overlap. So one of the questions is, has my performance at work deteriorated? Has my performance in my sport and my gym going, deteriorated, gone downhill? So you don't have that same get up and go from what you once did. I mean, the beginning of the questionnaire asks about, again, erections less strong, lack of morning wood, lack of libido, weaker, less strength. I think when I was growing up, everything had to be low fat. It was skim milk, no cheese, no whole eggs. And those are your foundation. And eggs are actually very good for the choline and good for your brain. These are the foundation of testosterone, especially if you're in adolescence. Getting enough sunlight, vitamin D3, making sure you get enough, B12. These all make an impact. Zinc is an interesting one because you don't want to take too much zinc without the copper because it depletes it. But zinc can also act as a mild aromatase inhibitor. That enzyme I think I mentioned that converts your testosterone into estrogen. Zinc can help give you a little bit less of that, but too much isn't good either. So, but if you are deficient in zinc, studies have shown your testosterone can go up. So if you have deficiencies, so testosterone that's not quite optimal because of deficiencies in nutrients, balancing those things out will help. And then sleep makes a big difference. If you're sleep deprived and do a blood test and you got this weird borderline testosterone level, having a good period of optimal sleep, you might see a big increase in testosterone. And then the other thing about testosterone testing itself, it's so random. It's like one point in time, and if we put a cannula in the vein and tested you every 10 minutes, you would see very different levels. I spoke to one endocrinologist at Imperial College in London. We're talking about a study he's doing with something called kispeptin. It's a peptide, kispeptin. And they're studying it for both diabetics, people with diabetes, as well as people who have basically hyposexual dysfunction. They don't have sexual desire. So how I told you about the LH and FSH that tells the boys to do their thing? There's a signal above that, actually two signals above. There's the GnRH, so gonadotropin releasing hormone, that tells the brain to release LH and FSH, and above GnRH is something called kispeptin. And it's like more recently discovered, and kispeptin may be the trigger that kind of sets up the puberty and the whole cascade of that working. But kispeptin can also improve desire and libido, so it hits maybe areas of the brain like dopamine. Speaking of which, HCG also hits some receptors in the brain that have to do with dopamine. There was a paper done in China about people with Parkinson's having some benefit on the dopamine receptors with HCG. So as a side note, this is why some men that will take HCG, maybe because they don't want to have children, they're not worried about fertility, they're not worried about the size of their testes, but they might feel a little bit better from a dopaminergic point of view. Wow. Yeah. So those guys who I think feel worse are easily agitated, and the sudden change in neurotransmitters, I think that's what it might have to do with.
Feel better.
Yeah. That's what, or they might be getting too much. I mean, because the problem is in some of the studies that they've done on HCG, they biopsy the testes after they give different doses of HCG. And the magic dose to get the most intratesticular testosterone when they did the biopsy was 500 IU 2 to 3 times a week. They looked at 250, it was neutral on intratesticular testosterone. 125, again, nothing really added to the intratesticular testosterone level, but nothing doesn't mean it doesn't do nothing for the brain. It does something for the brain as well. So I would use personally between 100 to 250 IU of HCG, maybe once or twice a week. And sometimes I'll skip, it's not essential. I'm not trying to go for fertility. I have done 500 IU 2 or 3 times a week. I'd been on testosterone for a year, at that time maybe 15, 20 years. I did a semen analysis. I can't say what my baseline was, but I'm assuming without much HCG ever, I got my semen count or sperm count to 175 million sperm, 156 million sperm, 75% motility, more than enough to get the job done. Well, I mean, there's different ways to access healthcare in America. You can go through your health insurance and you can find.
What you're saying is have more than one blood test.
Yeah, get more than one blood test and try to get at least testosterone, like I saw in your test, estradiol. I look at prolactin. I look at LH and FSH.
Where's that in the test that I showed you?
I didn't see LH and FSH on your test. They do, and I would do SHBG. I'm not so bothered by free testosterone. No, I'll tell you why. I like calculated free testosterone when your sex hormone binding globulin isn't way out of the range on either side. So if you're really...
What is the sex hormone binding globulin?
Yeah, I forgot to talk about that bit. So there's a protein, sex hormone binding globulin, that binds to your testosterone. And the stuff that's really, really tightly bound, and there's something that's like loosely bound. So the stuff that's tied to your albumin, it's another protein, is called bioavailable testosterone. And that disassociates, releases a bit more easily. But it's the free testosterone that's free floating in the blood that really tells you kind of where you are. So you can have cases where someone has a really impressive amount. Hey, those testes are putting out a good amount of the headline, total testosterone. But the actual amount that's free, and free, we like to calculate it because that's what they do on most of the studies, because the way they analyze the free, it sometimes overestimates how much free there really is. So it makes you think falsely that your free is absolutely fine, absolutely normal, but it actually, that's artifacts that the analyzer picked up, and that doesn't truly represent your free. So when you calculate it and compare it against the free testosterone assay itself, now you get a better picture. So there's many ways to look at it, but when SHBG is high, also there could be an issue with the liver. We know when you age, SHBG goes higher.
So do you want that lower?
You want it in the middle. If you have too low of SHBG, it could be representative of a metabolic condition like diabetes or metabolic syndrome, or people have too much sugar. Like having a high amounts of sugar and carbs actually brings SHBG down.
Yeah, because insulin lowers SHBG.
Yeah.
That's what
And
I said with my diet.
Growth
That's why we do
hormone,
it twice a week.
growth hormone can lower SHBG mildly. DHEA can actually boost IGF-1 and can also slightly lower SHBG. SHBG isn't good or bad. It is where your preset level is. It is where it is. I mean, there are techniques that I've seen. We have a Dr. Tuliatos from Greece. He's been on he's kind of a social media medical director guy. And he talks about a technique for fertility where he'll give like a clomiphene or N-clomiphene plus Proviron. And he uses Proviron because it's a strong androgen related to your DHT, and it will bring down the SHBG. So you get the benefit of having some additional androgens. And the reason why he does that is N-clomiphene or even clomiphene, more so clomiphene, the combination of the two, can raise the SHBG whilst you're on that treatment. So he can keep people's fertility going, give them an exogenous androgen, and it lowers the SHBG.
And it will lower estrogen.
And it will modulate estrogen. It doesn't block the enzyme, it just seems to block its effect the way it's being felt throughout the body. That's the simplest way to put it. And then the other one is there's a new drug, an oral testosterone. It's not really that new. There have been other versions of it, but they were at a lower dose. It's called testosterone undecanoate in a capsule that is like a liposomal capsule which you can swallow, and you should have it with a fatty meal. You take 2 or 3 times, I think it's 2 times a day. And that doesn't seem to shut the pituitary down as much. And in some cases, you can still have a bit of LH and FSH still going, so you don't really need HCG in some men like that to keep fertility and get a little bit more testosterone. And there's another testosterone treatment that you can put in your nose called Natesto. You can also probably get it compounded, where it gives you quick, short-acting bursts of testosterone in your bloodstream. Some people will feel a little bit better, but it's not quite the same as injections or creams. It's no, it's like a no. It's like a. I think it's like a. There's an applicator. Yeah.
I think.
If you like content like this, do click like and subscribe and hit the notification bell if you want to get our latest updates for when we drop content. It really does mean a lot. And until next time, to your wellness, this is Mike.